of all of them now, and is a very integral part of our melanoma program. And David will be talking about melanoma therapy. Where are we now? David.
Melanoma, specifically on staging and stage 3 and 4 treatment. Melanoma has been known as a disease that gives cancer a bad name. It affects young individuals, recurs unpredictably, and with researchers like Dr. Kushani's doing, we're trying to do a better job of being able to predict recurrences. Metastases, if not impossible, let's say they're difficult to treat. And there's quite a few cases every year, 64,000 cases approximately in America. My figures on yearly cases are a little bit different than Dr. O'Day's. I think that's because there's no perfect count of cancer in America. And also with the new diagnosis of melanoma in situ, I don't think there's uniformity in how those cases are determined. This is the official way of staging melanoma. All cancers, because we're just learning about molecular markers, as Dr. Kushani discusses, traditionally we determine prognosis by analyzing how far the tumor has spread. And I just want to simplify this to 4 stages. The stage 1 is a thin primary. The tumor's localized to the skin. Usually most stage 1s are less than 2 millimeters thick. Stage 2 is a thicker primary, greater than 2 millimeters thick. And I think, the staging of melanoma, it doesn't matter how wide it is. It only matters how thick it is. And conceptually, the true biology is much more complex, but conceptually I think as the tumor grows thicker, it's growing closer to those lymphatics and those bloodstream. It's going closer to spreading to the rest of the body. Of course, the real biology is much more complex than that, but thickness is our primary marker. I think it's also interesting to compare the thickness that we use to stage melanoma to the size we use to stage other tumors and take a look at comparative prognosis. A 2 millimeter thick melanoma has a worse prognosis than a 40 millimeter breast cancer or a 40 millimeter colon cancer or a 40 millimeter prostate cancer. Even when these melanomas are small, they can be deadly. And that's why we're all here. Stage 3 is basically simply local lymph nodes are involved. Stage 4 is when it's gone beyond the local lymph nodes. It's spread to distant organs or distant lymph nodes or distant sites on the skin. So the survival varies by stage. This slide's about a decade old, so it doesn't really reflect some of our new improvement therapies with stage 4 disease. But as you can see, the survival for stage 1 is pretty good, about 90%, 10 years. Stage 2 is not so good, it's only about 60%. Stage 3 overall, you're down to about 40%. And stage 4, you're really less than 10%. So fortunately, most patients are diagnosed with stage 1 or stage 2 disease. So what can we do? One of the questions comes up. You see a patient, they're diagnosed with advanced stage 2 disease or stage 3 disease involving the lymph nodes. Is there a treatment we can give that'll prevent recurrence, that'll improve their prognosis? We've known for 3 decades that with breast cancer and now also with colon cancer, lung cancer, prostate cancer, that if you add other treatment to surgery, the prognosis is improved. But we've struggled to find anything that will affect the prognosis of patients with high-risk melanoma. The key drug the one drug that has been FDA approved is the drug alpha interferon. It gets its name, it's a natural protein your body makes if you're infected with the virus. And it's termed interferon because it interferes with the multiplication of that virus or with a secondary infection with a secondary virus. When given as a drug, it causes quite a few symptoms. It's sort of like you got the flu that goes on as long as you're taking the drug. You get fever, chills, nausea. It can affect, cause sometimes some hair loss, low blood counts, and different autoimmune problems. The key study, the first large study looking at interferon, because studies of chemotherapy for stage 3 melanoma had proved quite futile, was started in 1984. That's why it's called E1684. And patients were randomized after a surgery to either get interferon for a total of 52 weeks or just get observation. And the interferon dosage was the first month you got really a pretty high dosage, 20 million units intravenous, go in the office 5 days a week for a month. And this is about the maximally tolerated dose because patients get liver damage or low white cells or other severe problems if you would try to go any higher than that. And then you're on a maintenance dose for a year. So this study was analyzed after about 7 years, and it improved survival. It's maybe a little bit hard to read, but the 5-year survival went up from 37% to about 46%. So it looked like it was really a substantial improvement. FDA approved the drug. However, one of the things that happened after that was they got longer follow-up. And the sort of the tail on the curve, the distance at the end of the curve, basically by 15 years, there's pretty much no difference. So there's quite a bit of controversy. You know, people have analyzed this study, put it together with other subsequent studies, none of which were quite as pure in terms of having a control group that had only observation. And it's clear that while interferon can delay recurrence, that the overall survival improvement is sort of meager. And there's also controversy over whether certain other factors should be taken in consideration when considering what to do. The European studies, which use a different form of interferon, seem to suggest that the most benefit comes with patients with ulcerated primary lesions. The therapy I just described is the whole 1-year therapy. There's an alternative treatment which has been used in Greece, which just uses 1 month of therapy, and that makes it more tolerable. But there's controversy as to whether that is as effective. It's been shown to be similar in a controlled study, but the study didn't have enough patients in it to really prove that it was of equal efficacy. There's another drug called GM-CSF, trade name's Leucine, generic name's Sargramostim, and it stimulates the white cells in the macrophages in the body. It was approved for use in patients getting high-dose chemotherapy for leukemia about 12 years ago. There's one controlled trial that does show that in certain patients with very advanced stage 3 or early stage 4 melanoma, that it helps with disease control, but it did not show any long-term survival benefit. There is, especially if it's given for longer than a year, there appears to be a risk of acute leukemia, and that sort of makes this not a real attractive option. Biochemotherapy, which Dr. Day and I have been advocates of for stage 4 disease, may have an effect in decreasing recurrence rates in stage 3 disease. However, it requires patients to be in the hospital for several cycles. There's a lot of nausea, vomiting, there's a lot of toxicity. Now, one of the most attractive options, or interesting options I'll put, for a stage 3 patient today is to go in a controlled trial looking at the new drug, ipilimumab. I'll be talking a little bit more about this drug, but this is a new drug that unleashes takes the brake off your immune system. It blocks the protein that's the brake on your T cells. And last year, a international controlled study, I think it's going to have 800 patients or so, was initiated using this drug for stage 3 disease. Patients are randomized either to get the drug or to get a placebo for a total of 3 years. And of course, it'll take several years to put the patients in the study and several more years to see the results. But it has a potential for really, I think, bringing us a step forward if it proves as useful in stage 3 disease as it has been in stage 4 disease. One advantage of this trial is that although some patients get significant side effects with ipilimumab, other patients may have just a little bit of rash and itching, or some patients have no side effects at all, so that going into this trial for most patients would not have the toxicity and the side effects that high-dose interferon for a year would. So stage 4 metastatic melanoma, once it's spread to distant sites, we have a real problem. It's fairly resistant to conventional chemotherapy, but it is curable in high-dose interleukin-2 or biochemotherapy in some patients. And this new drug, ipilimumab, can produce durable remissions in a small number of patients. And there's also evidence that anti-angiogenic therapy will be effective. The fifth point I want to bring up is that we're now able to analyze patients' tumors for specific mutations. One's a BRAF mutation, and the other is the KIT gene mutation. That does give us a molecular target rather than using non-specific chemotherapy or non-specific immunotherapy for targeting the specific gene mutations in the patient's tumor as we design our treatment. So here's an example of a patient that had pretty severe melanoma. He was a 21-year-old man that was a surfer, got the melanoma on the top of his foot, got conventional therapy. He got surgery, it spread up his leg. It also spread in one spot in his brain and his thigh. And despite an operation called lymphofusion, a conventional chemotherapy, it spread to what you see there. And he was treated with high-dose interleukin-2. Interleukin-2 is, it's called interleukin-2 because it is a protein the body makes in your white cells that stimulates leukocytes. That's why it comes named interleukin. And the inner, because it's made by one white cell to stimulate another white cell. And it turns your white cells into killer cells. You can show in a test tube and that you take the patient's white cells, you add high dose of interleukin-2, then you've got killer cells, you add those to your tumor cells growing in the test tube and it kills the tumor cells. Interleukin-2 doesn't kill the tumor cells directly, it kills them by activating your white cells to become killer cells. So after 2 months of treatment, you see the sort of yellow, pussy white cells. Those are the killer cells on his tumor. So we killed all his tumor. The black spots you see are residual just pigment because the pigment stayed there. You also see that around the black spots there's white spots or vitiligo because what's happened is we've turned some of his white cells into killer cells, but we've also turned some of his white cells into long-lived memory T cells that go after not only the malignant melanocytes, the melanoma cells, but also the benign melanocytes in his skin. So he gets develop white areas on the skin, which is a small price to pay to be cured of melanoma. Now, there's difficulties with high-dose interleukin-2 therapy. It was, approved for kidney cancer in 1992, approved for melanoma in 1998. but you have to be in the ICU to get it. You have to be under age 60 and be very strong. That's what high performance status is. It really has a high, even in the best of hands, there's a 1 to 2% mortality from the treatment. And the overall response rate is pretty low. The National Cancer Institute series, it was 15%. The number of long-term survivors was also very low at 6%. So it's remained unpopular as a treatment 20 years after its introduction. And of the 8,000 patients who die every year of melanoma, there's only a small number that receive it. So what has been developed over the last 20 years is trying to combine interleukin-2 using a little bit lower dose with less toxicity to conventional chemotherapy. And this approach was really started at MD Anderson in the early 1990s. The treatment program that I've used is one that Dr. O'Day developed about 15 years ago at St. John's Hospital in Santa Monica. The first 3 drugs are chemotherapy drugs. They're given in the hospital every day for 3 days. The 4th drug, IFN, is an abbreviation for alpha interferon. It's given in a pretty moderate dose, also to stimulate the immune system. And the interleukin-2 is given as a continuous infusion over 5 days. But the dosage, the first day, 36 million units, it decreases every day. The next day it's 18, the next day it's 9. So in contrast to the patient getting traditional dosing of high-dose interleukin-2, where they get sicker and sicker and sicker every day, here you hit their immune system with a jolt and high fevers, chills, pretty sick the first day. But by the 3rd and 4th day, you're reducing the dose and you don't have as severe toxicities. Patients 80–90% of the time are healthy enough to get out of the hospital the 4th day. And we give 6 treatments in the hospital with this, each 3 weeks apart. It's a very miserable treatment. I won't minimize that, but it proves easier to give than high-dose interleukin-2. Unresolved problems with it continue to be really a miserable nausea and vomiting, not only in the hospital, but for a week after, which I think some people in the audience can probably testify to. I did perform a retrospective review of 135 patients we treated with this regimen here at California Pacific, and it was, the patients got the biochemotherapy with decrescendo dosing of interleukin-2 for 6 cycles. Patients with CR is complete response, complete disappearance of tumor, partial response, partial disappearance of tumor, stable disease is disease unchanged. And one thing about treating stage 4 melanoma is, unfortunately, it usually grows pretty fast, so that if you're not getting it better, it's getting worse. So there were actually very few patients that at the end of 18 weeks you'd say, well, their tumor didn't change. Either got better with biochemo, which was about 55%, or it was getting worse and you had to go on to some other therapy. After that, the 18 weeks of biochemotherapy, we put patients on a maintenance biotherapy program that was also developed by Dr. O'Day, which is they go in the hospital just for 42 hours once a month for high-dose interleukin-2 and get outpatient low-dose interleukin-2, sometimes with the addition of the GM-CSF. And median age of our patients was 51 years. They were almost all stage M1A, M1B, and M1C are subdivisions of stage 4. They were almost all stage 4 patients. And what we found was that the response rate was actually pretty good, 59%, which is better than the 15% we see with high-dose interleukin-2 alone. The median survival, 16 months, is about double what you would expect with conventional chemotherapy. And most impressive was the progression-free survival, which is that whereas in the high-dose interleukin-2 series of the NCI was only 6%, here it's 15%. And both, when you compare those two groups, they're both phase 2 studies at single institutions. So I think it's reasonable to compare those two. One thing you also notice on this curve is that the progression-free survival, that is the patients whose tumor has not gotten worse, and really at 30 months, after 30 months, there were, on this slide, there were no relapses. I have to be honest, because, and the lack of relapses after 30 months really sets immunotherapy of stage 4 melanoma apart from conventional chemotherapy for colon cancer, breast cancer, and prostate cancer, where you always see more relapses every year. Here we have a cohort of patients where we really taught their immune system to reject their tumor. So even though patients go through a very miserable year of therapy, we have a substantial cohort that comes out the other side. Now, the data from the National Cancer Institute also shows the same 30-month cutoff. That is, virtually no relapses after 30 months. Now, I have to be honest, since I made this slide a year and a half ago, 2 out of 23 patients beyond 30 months have relapsed. They're both alive, but if I redrew this, there'd be a little dip in that curve. There's also a difference between progression-free survival and overall survival here. The overall survival, 25%, is actually fairly good for stage 4 melanoma. That's due to some patients that had their melanoma reduced to just 1 or 2 spots and went on to have surgery. Those patients would be not counted and still having progression-free survival. Also, a few patients that went on to other therapies like ipilimumab, and a couple of those are still alive. So this is the biochemotherapy remains a little bit controversial in America because of lack of really good controlled studies. The best, really the best controlled study was, which is really not very good study, but it was done by the Eastern Cooperative Oncology Group. And when they reported it at the American Society of Clinical Oncology meetings in 2003, they said, oh, it's a completely negative study. Nobody should use this therapy. And what they compared was the BCT was biochemotherapy, similar but not the same as what Dr. O'Day and I used. And they compared that to conventional chemotherapy. But when they finally, 5 years later, completely analyzed their data, for 2 of the 4 endpoints, it was actually a positive study. This shows progression-free survival, which was better with the patients that got biochemotherapy. There was also a statistical significant improvement in response rate. And their results were not as good as what I described for our group and for Dr. O'Day's group, probably because they didn't give enough treatment. Dr. O'Day and I give 6 cycles of biochemotherapy, and this group had been done in 50 or 100 different hospitals in America that weren't really very well, doctors and nurses weren't very well trained. They only got maximum 4 doses, but by the time they got the 3rd dose of, by the time the patient went to the hospital the 3rd time, the average patient was only getting 30% of the optimal dose of interleukin-2. So most of these patients, so that's, I think, is why you don't see a better survival rate, where here you see a 5-year survival of 8%. But people that say that biochemotherapy doesn't work actually need to read the Koch paper better. So I think in conclusions, you can see the selected patients with metastatic melanoma. We also did a study. We took a look at prognostic factors. And there's a blood test called LDH, or lactate dehydrogenase, which is an enzyme made by cancer cells as well as the normal liver. And it's been known for 25 years that if that blood test is elevated, your prognosis is poor. That's the oldest biomarker. So I think one of the obstacles with stage 4 treatment is the patient's physicians think it's incurable. Next, I'd like to go on and discuss a little bit the drug ipilimumab. I was a part of a study of using this drug in patients with melanoma, and we tried using one of the worst side effects of this drug is it causes severe diarrhea and can cause colitis in about 20-25% of patients. And so to try and prevent that, half the patients got the drug budesonide, which is a drug that's FDA approved for colitis. Now, this cartoon sort of shows how ipilimumab works. With your lymphocyte, your T cell, binds to either what in the lower is antigen presenting cell, or its binding to a tumor cell is really the same. What happens in the immune system is your body's antigen presenting cells, or macrophages, take up pieces of tumor cells, and the little red dot there is a little piece of a tumor cell. It's a tumor antigen, and it presents that to your immune system, the T cell. And what happens first is you not only have to have the binding that you see on the left between the T cell receptor and MHC, but to get your T cell activated, you need the binding on the right with the B7 and the CD28. But what happens after that binding occurs is your T cell starts making its own brake, which is the CTLA-4 molecule. And the CTLA-4 molecule has a stronger binding to B7, so you move over to the second slide. And when that happens, then the CTLA-4 binds to B7, and it gives the T cell the signal not to be active. It says, you know, this is a normal, this antigen is like it's normal part of your body, you shouldn't get angry at it. And the T cell's inactive. Now what ipilimumab is a monoclonal antibody, protein made through, and it's given intravenously. And it binds to the CTLA-4 antigen. So there's no immediate effect when you infuse it intravenously. But over a few weeks or months, what happens is when your T cells bind to tumor antigens, they all get activated. But at the same time, they also are constantly exposed to endogenous, your own antigens in your body, so you get autoimmune effects also. So, I'll sort of speed up here, we don't want to go too far over. The ipilimumab was associated with these autoimmune effects, and colitis diarrhea being the most important. In the first 100 patients, they had about, first couple hundred patients, they had a couple that died from the colitis with bowel perforation. So we did a prophylactic study of giving this budesonide to try and prevent the colitis. The bottom line was it actually didn't prevent the colitis. If you go down and see gastrointestinal, you can see that the grade 3 to 4 incidence of gastrointestinal problems was 24% with the budesonide and 22% without. But this slide also gives sort of the very peculiar, I mean, for a drug to cause rash is not unusual. But for a drug to cause autoimmune hepatitis, colitis, and inflammation in the pituitary, which is the hypopituitarism, is quite unusual. But with all these mapping the changes in total tumor volume from baseline, and upper left response in baseline lesions, you know, the best would be that all the tumors just went away and stayed away. But what we find with the ipilimumab, this form of immunotherapy, is in the upper right are two graphs showing two different patients, and both of them had that little yellow line. That's the appearance of a new tumor after the treatment was started. Despite the appearance of the new tumor, the new tumor then got smaller and they got better, and the patient eventually had prolonged survival. And the bottom right shows that some patients when you took a look at their tumors at 3 months, which usually with chemotherapy or biochemotherapy is plenty of time to see a response, the patient's tumors were actually a little bit larger. And conventional wisdom would have you, well, the treatment doesn't work, stop the treatment. But with ipilimumab, with continued treatment, or sometimes just with continued observation, because this drug lasts in the system about 6 months, the patient's tumors would shrink and they get better. Sake of time, I'm not going to discuss that patient. The other thing we're working on is looking at a tumor called tumor mutation called c-KIT, and this may be have mutated or be overexpressed in 10 to 30% of certain melanomas, including melanomas that are not related to sun, usually not related to sun exposure, mucosal melanomas, acral lentiginous. And actually, my last statement is probably not true. We probably do not see BRAF and KIT mutations in the same tumor at all. So we've started looking, we've now screened over 70 patients, so looking for KIT mutations, and the ones that have KIT mutations, we've started treating them with drug sunitinib, which is already FDA approved for a tumor called gastrointestinal stromal tumor, where they have the same KIT mutations. So I just want to give a rundown of what the research protocols we have available now at California Pacific. We have ipilimumab versus placebo for stage 3 disease. We have ipilimumab available on an expanded access trial for patients who have stage 4 disease that have received previous chemotherapy. We have Oncovax, which is a genetically modified herpes virus, which is injected into the tumor. We have the sunitinib for patients with KIT mutations. In August, we'll be starting a trial with a BRAF inhibitor. We're considering starting a trial of immunotherapy and targeted therapy. And Dr. Kashani is working on the molecular determinants. Thank you.